Hello, my name is Carrie Reynolds. I'm the clinical director of the inpatient oncology units here at Massachusetts General Hospital, and I direct our severe immunotherapy complications service. Thank you so much for clicking on the link to learn more about recruitment. So we are excited to work so closely with you in this Atrium clinical trial. It is truly a bridge between two worlds, between both cardiology and oncology. And in addition, it's the first large multi-center randomized clinical trial that will be recruiting 390 patients in the immune-related adverse event space. It's an exciting time, and we so value your feedback. It has been critical to everything that we do with the protocol. In addition, you've had considerable feedback when it comes to recruitment, and we wanted to address that with our short video here today. So the feedback that you have brought up, myocarditis is uncommon because it's only 1% of patients that are treated with immune checkpoint inhibitor. 2, is there a potential if we recruit to this study that there might be a delay in diagnosis or treatment? 3, others have brought up that you see various clinical presentations, some on the mild side that you treat outpatient that wouldn't be eligible, and some on the more serious side that have already met a cardiac endpoint, meaning arrest, shock, a bradyarrhythmia with one of those significant heart blocks, or a tachyarrhythmia lasting over 30 seconds. Others have brought up that there's still a lack of disease awareness where they may be or in the community. And others have brought up that you are geographically dispersed, meaning there is a site that is a large academic site, but there may be more sites that treat patients in the network or the community. So we wanted to address each of these. 1, myocarditis being uncommon. It is true that the FDA is approving more and more immune checkpoint inhibitors. There are now over 80 FDA-approved indications for checkpoint in cancer. In addition, just last month, LAG-3 and PD-1 combination were approved in melanoma. And so we think over the study period, there will be an increasing number of approvals and an increasing number of patients that receive treatment with immune checkpoint inhibitors, but is still only 1% of patients. I think what's important to bring up is that this study is unique in that we do not think that any one site will have an extremely high recruitment, but the important part is to try to ensure that we get the eligible patients. It's more like a treatment with a rare disease or a rare cancer. In addition, for that aspect alone, the clinical trial protocol has been broad. So any cancer type is eligible and any stage. So if the immune checkpoint inhibitor was used in the metastatic setting or the adjuvant setting or even the neoadjuvant setting, all of those patients are eligible. As far as the second point, for the potential for delay in diagnosis and treatment, we want to reassure that patients can have already started on corticosteroids and they can be on standard of care dosing with a gram of Solu-Medrol as they are recruited and enter the study. 3, for the various clinical presentations, we all remember those patients, obviously, that have met a primary endpoint and are the most severe. However, the majority of patients at least dictate that, that they would fall within the parameters of what the eligibility are. So we are hopeful that we are hitting the large majority of those patients. For disease awareness and for the fact that certain centers are geographically dispersed, others have brought up very interesting ideas to try to deal with this. So we wanted to share those best practices. Some talk about following the patient's journey. So if there's a myocarditis patient and say, do they ever hit the outpatient oncology clinic? Do they hit the infusion center, the emergency room? And when they're in the emergency room, do those emergency room providers, do they page the onc fellow or the cardiac fellow? And how do those fellows get the attending help that they need? What's the service structure look like? And where do those patients go? Do they go to the medicine floors or the cardiology floors? Or do they go to the ICU? And if it's an ICU, do they go to the medical ICU or the cardiology ICU? Each institution will vary, but really making sure that all of those touch points are aware of the trial is going to be important. Whether that's by having talks or sharing cases, making sure they know about the Atrium trial, whether that's posters or buttons, there will be a wide array, but bringing that awareness to those individual locations to follow the patient's journey will be critically important. And that kind of goes along with the second point to ensure there's several champions at the site. So both cardiology and oncology, maybe there's fellow or trainee champions as well, but bringing everybody together. At our own institution, we have individuals interested in immune-related adverse events and the severe immunotherapy complications service, and we meet every other week. That might be too frequent, but maybe it's once a month or once a quarter. Just key to keep the study top of mind, given that it is an uncommon presentation. And lastly, others have brought up that they're going to increase their connection and outreach to the community, meaning really making sure each of those sites are aware, and for the right patients that hospitalized with a troponin over 5 times normal and myocarditis, that if it's within the goals, they may be transferring to the central center as well, where the study is held. We have no doubt we can recruit to 390. We also know that it will take a village, and we're so excited that you're part of that village. So thank you.